In isopure, beyond this equation, you have a few additions. These few additions are actually for the free-form optics and the curvature changes that happen. However, the difference from the Vivinex Impress is this has it in the whole of the optic, and yet it does not produce any compromise with the quality of vision. How does it do it? This is how it does it. Both the surfaces are aspheric. Both the surfaces are complementary in design to one another, as you can see here. So there is this base curve of the IOL, then the curvature changes happen at the inflection points, but the inflection points are there on both the surfaces. So whatever convergence you need can be divided into half and half. The anterior surface does it 50%, the posterior surface does it 50%. So you do not have a gross change in the surface geometry. The quality of vision is not compromised with, yet the job is achieved. So the depth of focus of a 19.5 diopters IOL, for example, of Micropure, which is a monofocal IOL from the same company, will produce this much of depth of focus. For a 19.5 isopure will produce the depth of focus which is stretched out. However, the distant visual acuity in terms of logMAR mildly drops, in terms of MTF mildly drops, which is pretty much acceptable. The peaks of this IOL, again, the defocus is very, very consistent. What you achieve in one patient is what you can achieve in 100 patients. You can confidently pitch for that into the patient's minds. There is a material advantage. It's a hydrophobic IOL, and the water content, though, is slightly higher, but the performance is excellent post-operatively. It behaves much less rigid than the other hydrophobics in the market because the water content is slightly increased and also makes it glistening free, essentially. And the defocus is much better with larger pupils. So we just talked about the Impress here. When pupil enlarges in a photopic pupil, I'm not talking about a mesopic condition. In a photopic pupil, when you have a large pupillary condition in a photopic pupil, the Impress actually slightly underperforms because the peripheral girdle, which is dedicated for distance, actually comes into play. But the isopure, since it has these changes right throughout the optic, even if you have a larger photopic preoperative pupil, you can still go ahead and select this lens because this will perform exactly the way it should. Troughs are the toric trim. I'm not very sure about the design and the toric trim being available on this platform. The PCO profile is something that theoretically raises a question in your mind because the water content has increased. However, the user feedback from all around the world globally has said that it is performing beautifully, and I have more experience with the toric version, monofocal toric version coming from with the same platform, and it behaves absolutely fantastic. There's no PCO profile, and it sits in very well with the capsule indeed. But that's something that we need to keep in mind, and it needs to be studied as we implant more and more. This is the typical depth of focus curve. Look at this depth of focus. This is almost 1 diopter, and this is the average depth of focus that I've taken into account. In some patients, it actually exceeds 1. It goes into 1.13, and the distant visual acuity is also sharp. The peak is also sharp. Both of these IOLs can be combined into one. We'll just come back to that later. Impress and isopure, because they work on the same technology. And how do I choose my patients? Remember one thing, any lens that works on the free-form optics principle, the defocus will be much better when you have the myopic range of patients, when you have the IOL diopter less than 20. And the defocus drops when you go to the hyperopic range. This is also true for both of these IOLs. That's true. So when you see the IOL power that has been calculated, you can imagine how much is going to be roughly the depth of focus, and accordingly you can pitch to the patient. Both produce consistent defocus, as we saw. Peak of the VS-OTF curve of the Impress slightly edges past the isopure, but the isopure performs much better in large photopic pupils. Sorry for the typo. Large photopic pupils, as we just explained. Large capsular bags, if you have a myopic patient, the C-loop haptic performs slightly better, so the Impress performs slightly better. But if you have a hyperopic eye, if you have a small capsular bag, then the isopure exceeds the Impress in its performance. So we'll just come back to the previous slide. This is what is the crux of the enhanced monofocal IOLs and why they constitute a major part of my practice nowadays. This curve is known as the encircled energy function. What does it show? It shows, look at the cornea here, and I don't know whether it's visible to you or not, but can you see the 1 written over here? What it means is the cornea is allowing 99% of light energy to pass through. It is destroying only 1%, all right? And after the IL implantation, if you look at the total eyes encircled energy function, it shows 2 to you. What it means is, from the cornea to the IOL, when the light energy travels, the IOL per se is causing a decay of light only to the extent of 1%, which means 98 to 99% of the light energy is still available. This is something you can find only with enhanced monofocals. This is not something you're likely to find with trifocals, definitely not. And even with most of the EDOFs, some amount of, a good percentage of light energy is lost. The other aspect of enhanced monofocals is the point spread function. This is the rough and average point spread function of both of these IOLs, both the Impress, and I was talking about the Impress and the Isopure there. This is a typical PSF taken particularly from the Isopure. The Impress actually fuzzes out a little bit, but when you talk about, since it's present in the whole of the optics, this is the point spread function. Look at the tightly knit PSF that we have on the foveal point. You can imagine what the clarity of vision, what the quality of vision is going to be. It's going to be very sharp on the image point of view, from the image point of view, and it's forming a deadly knit, closely knit conglomeration of light energy at the center of the fovea. So these were some of the IOLs and their principles. Thank you so much for the opportunity, Sheetal.
Thank you so much, Dr. Anurag, for breaking down such a complex topic, explaining the principles and the technologies. So, any questions for Dr. Anurag? Yes, please.
Need to measure the angle kappa always before implanting any EDOF? Or if you don't have the facility to measure the angle kappa, which lens would you prefer?
No, kappa is actually not that important, but the alpha is in choosing IOL. And if you're not implanting a monofocal, if you're going beyond that, be it an EM, be it an EDOF, be it a tri, the alpha should be measured. I do not buy the the proposition that is put forward by many authorities that angle alpha is not important, because I've got evidence and loads of it to prove that angle alpha is very, very important. I'll just give you an example. When the VVT was launched, and it's still said to be a universal IOL, almost every patient can receive it. Wrong concept. The VVT is more sensitive to decentration. If you're putting it in a perfect patient who should receive it, the results are fantastic, phenomenal. But if you're not putting it in a patient if you're putting it in a patient in which the alpha is more, and it's likely to be decentered in the central zone, the central surface change is shifted a little coronally, then the results are devastating. So if you can, you should. And if you do not have access to, as you pointed out, to a machine that measures the angle alpha, because iTrace is the only equipment that measures the angle alpha, then I believe you should get it done in another center which has access to it close by to your practice. But I believe it's always a better idea to see that before you plan any such IOL. That's not a monofocal.
Can we put these lenses in diabetics and patients with glaucoma?
Absolutely. These are, from those senses, from comorbidities, ocular or systemic comorbidities, these are universal IOLs. If the condition of the optics, the light path passing through the eye, if there's any aberration in there, you will think. But comorbidities do not pose as a contraindication. Yes, sir.
The Johnson & Johnson launched another lens, which the Pure C. So how does it differ from the Eyehance lens?
That's a question I asked them too.
Yeah.
To me, to me, structure-wise, the Pure C differs from the Eyehance in two aspects. One, the refractive change in the Pure C is in the posterior surface. The Eyehance has it on the anterior surface. Two, the refractive change in the Eyehance is located in the central 1 millimeters. In the Pure C, it is stretching to 3.5 millimeters. Apart from that, both of them, as far as the design factor is concerned, are almost similar. There's hardly any difference. But the defocus that is produced with the pure C is slightly better
Hello?
because the curvature change is more steep on the posterior surface. So we will discuss that, we can discuss that at length later on, but it adds both spherical, positive spherical and negative spherical aberration to the system of the eye, and that's how it produces the defocus and shifts it back to the foveal plane. The pure C is a lens which is very, very largely pupil dependent. You will not get the same defocus in all pupillary sizes. When the pupillary size goes up from 3.5 to 5 millimeters, the defocus substantially drops down. So it's not very consistent in producing the defocus if the pupillary size is not behaving properly, obediently. The cost difference is huge, obviously, because that's pitched as an EDOF, a proper EDOF. This is pitched as an enhanced monofocal. So the cost difference is, the one thing that has come with the Pure C, which was not there with their earlier products, is the preloaded assembly. Johnson & Johnson has really worked on that aspect, and the preloaded assembly of the Pure C is magnificent. That is one thing that where they have really worked hard, and they've really made it well. Can't hear you, sorry.
Is the pupil size important, like in case of Vivinex Impress? It is there in the central 2 mm. So if a patient has a pupil size which is approximately 2 mm, so the distance vision will get compromised there in those patients.
To my experience, the Vivinex Impress acts pretty well till the photopic pupil stretches to around 3.5 millimeters. But beyond that, if the photopic pupil is dilated more than that, and somebody is trying to, say, read something under low light, then he would not be able to. Even if it's kept at 66 centimeters, he would not be able to. So that's where it underperforms. That's where the ISOPIO scores.
Have you any experience in using these lenses in post-LASIK eyes?
Yeah,
Do you use them?
Yeah, that's a very good
regularly?
question. Actually, yes, I have. And in post, all refractive surgery, while LASIK only, all refractive surgeries, if you do not have much of corneal aberrations generating from the laser procedure,
Yeah.
then they work very well.
True. So next would be myself. So I'll be presenting on 4 haptic design enhanced monofocal IOLs. So basically the EDOF lenses, or the extended depth of focus IOLs, they were introduced with the idea of bridging the gap between the monofocals and the multifocals, and to give you the best of both worlds. And the lenses which are available today in this category are IC08, Symphony, AT Lara, BBT. These are the common lenses. Now, what is characteristic of these lenses, these EDOF lenses, is a depth of focus which is around 1.75 to 2 diopters. So this is the list of all the commercially available EDOF lenses, and you can see that most of them are having an depth of focus which is around 2 diopters. You can see here. Now, however, so this 2 diopters of depth of focus is actually good to give good intermediate distance vision, intermediate vision. However, these lenses do have some limitations, such as the IC08 was known to later have a loss of light, basically because it works on the pinhole pupil concept. The Symphony or AT Lara basically has a diffractive design, hence definitely you can expect halos and glares. And the VVT in many studies have found, it has been found that it can lead to some amount of loss of contrast sensitivity post-op. So even though they give good intermediate vision, but then they were found to have limitations in the long run, and also in clinical studies which were published. So this is where the role of enhanced monofocal IOL comes. And these lenses, I would say, score over the traditional EDOF lenses because they have, although a slightly smaller depth of focus, which is around 1.5, however, they do give functional intermediate vision along with a good quality of vision. So you are getting functional intermediate vision, but without any kind of compromise on the quality of vision, no halo glares, no contrast disturbances, and also no drop in the distance visual acuity. So I'll be talking more about the ISOPure Serenity and Serenity Toric technologies from BBI. And Dr. Anurag has given a brief overview about these lenses, but I'll be discussing more in detail. So basically, the Serenity is, so now we have this ISOPure Serenity and Serenity Toric, which is actually the second generation of the ISOPure enhanced monofocal lens, which was already available to us in India. So this lens was based on this 4 closed haptic design with posterior haptic angulation. So you can see that this design is very characteristic. This is 4 haptic design. And these haptics are closed. This is the loop design, also known as the bunny design. Now with the Serenity and the Serenity Toric, basically these are the ISOPure generation 2 lenses. And how they are different from the ISOPure, essentially the principles of working are same, but they differ in the design of the lens. And also now the Serenity Toric will be available. It is already introduced in Europe in many countries, and it was introduced in the last ESCRS conference, which was there in Barcelona. However, it is yet to be introduced in India. So that's an update from the ISOPure on the ISOPure lenses. So when we say this word ISOPure, if you break it down, basically ISO means equal. So it is used to describe a uniform increased defocus. Pure means, as we understand, it is not mixed or adulterated, so it's clean, clear, and refined. And it is used to describe the hydrophobic material, which is free from any impurities or glistenings. And Serenity, which is the new word, which is now the new term, these lenses will be now known as ISOPure Serenity and ISOPure Serenity Toric. So Serenity, as we understand, is the peace of mind. And this aims to deliver to both the surgeons as well as patients peace of mind through trust, which we already had in the ISOPure optic, combined with the pod platform, because now these lenses are available on the pod platform, which is the open loop design. So this is the ISOPure Serenity features. So you can see this is the new design, which was already available on their monofocal toric platform. So this is the pod design, which is a double C loop design. And you can see some ridges on the haptic. So this is called the ridge tech technology. The lenses also have posterior angulated haptic and the overall diameter of 11.4 millimeters. So basically, this is the Serenity Toric, essentially the same platform. Now these lenses are able to correct a cylinder of up to 6 diopters on the IOL plane. So the principle on which these lenses, which is the ISOPure Serenity and Serenity Toric work, is also discussed in the previous talk, but I would go further in detail. So what this ISOPure technology aims at, it basically aims at providing you with a consistent depth of focus in each eye, and how it achieves is basically by incorporating spherical aberrations across the full optic diameter, and not only on the full optic diameter from center to the periphery, but also on both the surfaces, both the anterior as well as the posterior optic surfaces. So unlike the other designs where the spherical aberrations are introduced in the center, let's say in 1 millimeter or 2 millimeters, here it is basically incorporated on the entire optic, and this gives it 2 advantages. The first advantage is that it gives you a consistent depth of focus, and secondly, it makes it pupil independent, as was discussed earlier. So due to this, what you achieve is a range of vision, wherein this was compared with a monofocal lens, which was the ISOPure, which was the monofocal from the same company. And what you see here in this diagram is that the ISOPure Serenity provides a depth of focus which was approximately 50% more than the monofocal lens, and with only a 12% decrease in the maximum MTF. So this is equivalent to approximately 1 diopter of extended depth of focus, which is slightly more compared to some of the other models. discussed previously. And again, this is another study where you can see that at the 1.5 deep focus point, the isopure serenity provides an intermediate vision of 0.2 logmar, which is an excellent intermediate vision. Now, how it is able to provide a consistent depth of focus across all ranges is, again, we come back to the isofocal technology. So we said that here the abrasions are introduced on the entire surface from center to periphery and on both the surface. But furthermore, what happens is that here they have also adjusted the value of the negative spherical abrasions as per the individual lens power. So this is something which is very unique to only these lenses, wherein you see that depending upon the lens power, these abrasions are customized. So if you have a myopic patient, so we say that standard corneal abrasions are 0.27 microns. That's a standard spherical abrasions. However, they differ in myopic patients and hyperopic patients. So when you see a myopic patient, on an average in myopia, you have about 0.24, which is slightly less than the average. And a hyperopic patient will have slightly more, like a plus 0.34 than the average. So these are the positive corneal spherical abrasions, which vary depending upon myopia or hyperopia. Now, if you do cataract surgery for them, you will have to implant a lens of myopic or hyperopic power. So their curvature and shape is going to change. So we understand a lower positive power lens will have a concave convex curvature. You can see here plus 10, it has a different shape. And of course, for a hyperopic lens, as you go higher with plus 35, it's a biconvex shape. So with the shape, ideally the abrasions should also change. The abrasions induced on the lenses should also be customized. This is what is done in isopure technology, the isofocal technology, wherein the other technologies, it is a fixed amount of spherical abrasions which is incorporated. So they do not consider the power and the curvature of the lens into account. And here in this technology, this is done. So this is why you always get a consistent depth of focus, whether it's a myopic patient or a hyperopic patient. And I'm also seeing this practically in many of my patients, this result. So due to this, what you get is the right balance of the range of vision and the quality of vision. So if you compare the isopure, with isofocal technology, quality of vision versus the depth of focus, on the extreme right, you see that it is well balanced, the quality of vision and the depth of focus, whereas on the second one, you can see this is versus the other lenses, other enhanced monofocal lenses, you can see there is some amount of asymmetry. So those lenses with the, excuse me, the myopic lenses will have more depth of focus but a less quality of vision, and as you go towards hyperopia, the quality of vision is more but the depth of focus achieved is less. So you can see there is some amount of dissymmetry, but with the isofocal, despite the power of the lens, you can see that it is very well balanced. So the quality of vision and the depth of focus are balanced with this. Also, the quality of the GFY material, which is used to manufacture these lenses, has been shown to have a very low PCO rate. And this essentially is based on the no space, no cells concept, which basically was a concept introduced by Dr. Linola's sandwich theory. And this is basically done to provide a perfect bioadhesiveness, to provide a hard tackiness and bond to the capsular bag so that it sticks well to the capsular bag and prevents the migration or the proliferation of the cells. And it also has a two-step technology which features a square edge barrier and posterior haptic angulation. So this also offers protection against PCO. And in long-term studies, it was found that the PCO rate was very minimum. And this is a study which had long-term follow-up of 3 years. And they found that only 1 out of 43 eyes at 3 years underwent yak capsulotomy at 37 months. So coming to the stability and coming back to the pod design, so this design essentially aims to provide better stability, positional stability in the capsular bag. And how this achieves this excellent stability is because of the double C-loop haptic configuration for excellent fixation within the capsular bag. So it provides 4-point fixation, and this offers low tilt and axial displacement because it is so stable in the capsular bag, it does not really tilt, so it is tolerant to some amount of tilt and decentration, and is also very stable in the bag and has excellent rotational stability. So if you see this diagram, basically it has a greater contact angle. So why this pod or open double C-loop design is considered to be more stable is because of its greater contact angle. Here you can see in comparison to a C-loop design. So a C-loop haptic design, which is actually the overall length, it has is 13 millimeters. Now when you compare the contact angle, which is shown by these red arrows, you can see that the 4 closed haptic design, this is of course this is the older one, but this goes the design of the open C loop, which is the pod, is actually more stable, and it provides you with 70%, more than 70% contact angle because of its 4-point stability, 4-point fixation. And what it offers additional stability to the lens is the ridge tech technology. So you can see that there are some ridges on the haptics. This essentially reduces the risk of sticky haptics on the optic during and after the injection. So when you're injecting the lens is folded, so it does not cause those optic haptic adhesions, and it opens smoothly and does not stick. So this design, because you can see that it has rounded edges, so it is easy to maneuver in the capsular bag. So unlike the traditional C-loop lenses, which can be rotated only clockwise, this particular design can be safely rotated in both clockwise and anti-clockwise direction without any additional trauma to the bag. So I would just show some of these studies which have shown that the double C-loop design is very stable, and in this particular study they found that the rotation at the end of 1 year was only 1.22 degrees in the toric models, which is phenomenal. So coming to my experience with the ISOPure enhanced monofocal IOL, of course we are waiting for the Serenity and Serenity toric, but so far I have a vast experience with the ISOPure lenses. So this is the data from the first 25 patients. So 20 IOLs were implanted for the 10 bilateral patients. The first eye was targeted at emetropia, or the first plus or minus, whichever was the least. Second eye operated within 2 weeks, and the second eye was targeted at 0.25 to 0.5 diopter minus after considering the first eye outcome. And if the patients desire to read better, then we also did up to 0.75. So here you can see the surgical implantation of the ISOPure. So some surgeons feel that it is technically more challenging. However, I don't think so. If you use the right technique, it is not very challenging. So here you can see that how I am implanting it. So it's very important that the leading haptic should first go in the capsular bag, and then for the trailing haptics, you can actually just use your second instrument to gently push those trailing haptics into the capsular bag. And it is better not to do a wound assisted implantation initially in your first few cases, because if you do a wound assisted, then the trailing haptics will be released on the iris, and then you might have to struggle a little bit. So if you are well inside the anterior chamber when you're implanting the lens, you don't face this problem. So these were the results at 1 month, binocular results. Mean post-op UDVA was 6/6, 0.3 logmar. Mean post-op CDVA was 6/5. Mean distance corrected intermediate vision at 66 centimeter was 0.14, which is around 7.5 to 6.9. Distance corrected near vision, since we also did mini monovision for most of our patients, we checked the near vision as well, and this was excellent, N8, or every patient was actually able to read N8 with both the eyes, and some of them were also able to read N6. So mean post-op spherical equivalent was plus 1.12, and none of the patients reported any halos or glares or starbursts. So about the post-op reading addition, and this is the data for the 20 eyes. As you can see here, most patients, that is 18 patients, required only a reading addition of plus 1.5 or 1.25. So the need for reading addition also actually reduces. And this is the comparison of the internal MTF with a Technis 1 monofocal of isopure. And you can see here the average MTF height with the Technis monofocal and isopure is quite comparable. So Technis 1, as we know, is considered as one of the standard and gold standard lens to be compared. So it's quite comparable with Technis 1. And this is the subjective contrast sensitivity for topic. Again, isopure versus the Technis 1, where you can see that it closely matches the subjective contrast sensitivity on CSV 1000. And when you increase the light, basically in the photopic condition, you can see that compared to a Technis monofocal, it very slightly drops only at higher frequencies, which is expected. So to conclude, the isopure enhanced monofocal IOL, in my experience, provides excellent functional intermediate vision, which was consistently seen as 0.14 logmar or better in all patients, and some amount of functional near vision also. You can do a mini monovision of 0.5 diopters safely with these lenses. So this will help to reduce the near ad. Absolutely no drop in the distance visual acuity when you see these patients with both the eyes, when you measure the distance visual acuity. No halo glare or any kind of compromise on quality of vision was observed. Very high patient satisfaction. All patients scored over 95% on a scale of 100%. And I feel that these excellent results are achieved with a combination of closed pore haptic design, and now of course the Serenity, which is the open, and the pod design, and the glistening free material, the isofocal optic. All of these in combination provide excellent quality of vision in all varieties of eyes, irrespective of the myopia or hyperopia or the pre-op pupil size, angle kappa, alpha. I think it gives very consistent results in all types of eyes, and the patient satisfaction and surgeon satisfaction is also excellent. Thank you so much for your kind attention.
As you come back to occupy your seat, Sheetal, of course you don't need it, but I still, in the interest of the paraphernalia that is to be performed, Dr. Sheetal actually forgot to introduce herself. Dr. Sheetal Brar is, as we all know, a very, very well-known and internationally acclaimed figure who not only understands science and technology, but also puts it on paper. So she publishes a lot right now, working as the director of ProSight Eye Hospital in Batinda. But she has been, you know, she's, sorry, Chandigarh, I'm so sorry. I just get confused with the names. People get confused with the name of my state as well, so it's quite even Stevens there. Right, so she has a very illustrious academic career, and we just saw why, going to such micro details of analyzing and dissecting a product before she starts using it, and after she uses it also, the kind of post-operative data that she's come up with. Very invigorating, Sheetal. Thank you.
Thank you. So, Dr. Sono, sir, you are ready? Yeah.
One of the interesting things of the one of the interesting observations that I've had with this horizontal serrations that these four haptics have is, apart from the fact that they do provide additional stability, when we fold the IOLs onto the cartridge, the visco acts as a glue, and oftentimes the haptic which is folded onto the optic surface stays attached, stays adhered, and it takes quite a while actually to separate them. So it's called the salami sign on C-loop haptics.
Dr. Sonu Goyal.
Because of the horizontal serrations on these products, when you fold them onto the cartridge, they actually never glue to the optic. They always open up quite predictably, whether you implant it under visco, under BSS, whatever. I think the other thing that you mentioned about the surface area being larger, initially when it came, the overall diameter was even less. I think it was around 10.5 or 10.75, then they slightly increased it to 11.25. So with such short dimension, such short overall diameter of a product, we always have the jitter of the rotational stability post-operatively, because we know that the bag is going to contract from the fornices and it's going to displace the IOL maybe. But interestingly, what we have found is over the last few months, or over, I think, close to a year that I have started implanting the pod iToric, the post-operative results are very consistent, and the rotational stability is actually very, very good, which I was honestly speaking not expecting to be this good. And across the IOL diopters as well, myopic eyes, the hyperopic eyes, across the toric trims, T2 to T7, T8, everything performs uniformly. So I believe because of this contact surface, the surface contact being increased, by the time the capsular contraction begins, it already has a very firm adherence to the posterior capsule, so it doesn't move even a micrometer.
I think that reduced size is compensated by increasing the
True.
contact angle.
Yes.
Because
yes.
when you have a large contact angle, you don't need this big lens.
Absolutely.
The size actually has to be smaller. So it's my pleasure to introduce Dr. Sonu Goyal. He does not need any introduction though. A distinguished ophthalmologist and medical director at Anand Eye Hospital in Jaipur, which is one of the leading eye hospitals in Rajasthan. Known for his excellent live surgery and oratory skills, Dr. Sonu brings a wealth of experience in cataract surgery and a passion for advancing vision care. So he has always been on the forefronts of technology and has been using cutting edge technologies and premium lenses in his practice. So today he will be sharing his insights on enhanced monofocal IOLs and how does he place these IOLs in his practice. We will discuss the counseling, pricing and insurance aspects. So I think Sonu sir prefers to have a open discussion on this topic. So, sir?
So a very good morning, and thanks Sheetal for that nice introduction. I'm really grateful. And so I think it's a wonderful design course, and taking ahead, how do I place enhanced monofocal IOLs in my practice, counseling, pricing, insurance. So before we begin and before we talk of any product to the patient, I think we in our own self should be first convinced how good is the product in terms of the vision recovery and the kind of result that we are giving to the patient. So your own, getting your own self-counseled first with the product is very, very important. You have a gamut of lenses which you can offer to the patients. So you can talk about trifocals, EDOFs, enhanced monofocals, torics, but the patient understands which lens will give me the best result. So ultimately, as clinician, you might offer a basket to the patient, but what is important is what you want to offer and what you feel secured and assured of the results. The day this concept of advanced monofocal IOL came in, I think it gave us two big advantages. Number one, some kind of an additional benefit to the patient in terms of distance and intermediate, or maybe a kind of a vision where the patient will be able to do all his routine household works without the need of additions. And at the same time, we as practitioners who were practicing monofocals in a particular segment would step up to a premium, not exactly to that level of trifocality or multifocality, but somewhere in between. That's what I stage these lenses in my practice. So convincing your own self, because we have seen, and as Sheetal has shown, advanced monofocal IOLs would give you a very good distance and a very good intermediate, and once implanted bilaterally, fair near vision, where I would talk to my patient that without the need of an addition, you can do most of your household works, but whenever you are reading fine prints, you might require an add of 1.5 or maybe 2, depending upon your own residual accommodation or your own ability in the retina. So enhanced monofocal IOLs, we all know, they have an advantage over the monofocals. They have a key benefits because they are giving patients the better visual outcomes. At the same time, there is no downside. So no halos, no glare, no starbursts, and ideal for patients who are seeking quality distance with minimal dependence on glasses. If you scroll through the market for the advanced monofocals, I think all companies have their own baskets, and Isopure by BVI, Raven from EMV, Vivinex Impress by Hoya, Aspire by Bausch & Lomb, Extend by Hanita, iHance by J&J. But I think going for a meta-analysis, if you see, all these lenses fare well. Now, what is the essence? Different lenses play differently, but the main essence is that the optics provide a higher order aspheric anterior surface with a continuous power progression from the periphery to the center of the lens, which gives you an add of intermediate vision. So this is, to quote, this is how a monofocal would look like, and this is what the advanced monofocal, you can see a central slight, where there is an kind of a profile which adds to your depth of focus. Short, but this lens that we have been using, Isopure from BVI, and over I think 500 lenses that we have implanted in last 6 months has given us excellent results, and J&J iHance also on the same platform. But what differently did this lens for us was that it works for all range of refractive error, which the other lenses would not in extreme cases of myopia and hyperopia. So essentially, the extended range of vision that we talk is basically if you increase the depth of focus by approximately 50%, there is a 12% decrease. So if you decrease this MTF by 12%, the depth of focus increases by 50%, and that is where equivalent to an approximately a diopter of extended depth of focus. So that's the principle where these extended monofocal IOLs would work, and that is what gives you that kind of an extended range of vision. So we have known for ages the average spherical aberration for a 6.5 millimeter pupil on the cornea is plus 0.27, but this could vary in myopic from 0.024 and in hyperopic 0.034. So none of the lenses are customized depending upon the refractive error as compared to Isopure, and this is how this delivers on the profile that the patients usually have. So if you see here, this actually varies depending upon the dioptric range. The corneal spherical aberrations are here, and this is the dioptric range, and where the competition available in the market would kind of balance this out. And this is how this isofocal technology balances the already existing corneal spherical aberration, and that is what delivers you the intermediate at all dioptric power. One good slide that I share from one of my colleagues is this dysphotopsia profile, and this is how a monofocal IOL, even for a 0.5 diopter of hyperopia, would behave, and this would behave even with a minus 0.5 diopter of myopia. Similarly, most of these advanced monofocal IOLs have a similar profile. So what I want to reiterate here is that if you want to do a kind of a micro monovision where you just want to make one eye for distance and the patient says that, look, I want to see a little for near, you can mix and match of minus 0.5, and this doesn't actually disturb the, doesn't create any kind of a photic phenomena. So the dysphotoptic symptoms would be almost similar what a monofocal IOL will end up giving. So it works very well. This is one of the papers in the Journal of Clinical Medicine, which talks about the enhanced monofocal intraocular lenses. It talks about the retrospective study, which compares the three basic models available in the world market. Essentially, the defocus curve with the iHance, the Impress, and the Isopure, no proprietary interest here, actually almost balances and equivalent for all the three lenses here. The binocular contrast and the special frequency is almost equivalent. So that means The Technis Enhance, so the study concluded that the Enhance, the Impress, and the Isopure, though they may be based on different optical profiles, they showed similar results in terms of visual outcomes, the aberrometry, and the photic phenomena perception. But I think the outliers lies with the Isopure in the extreme range of myopia and hyperopia. So these represent an interesting option in the standard of treatment of cataract patients. So that is where our journey starts. So I think once we are convinced with the technology that we are using, yes, this lens is going to work, we have to choose who are the ideal candidates. So I, in my practice, would rarely find a patient with a big no for these kind of lenses, except patients with keratoconus or patients who have undergone hyperopic LASIK or patients with abnormal corneal spherical abrasions, and rest all those patients with retinal disorders, with glaucomas, with abnormal corneas, they're all candidates where instead of a monofocal, you can always go in and chip in for an advanced monofocal IOL. So I think the patient exclusion criteria stand almost similar to the monofocal platform. So whenever I talk to my patient, I usually counsel that, look, we have 3 baskets of lenses or options available. One of them would give you distance, intermediate, and near, that in routine you will not be requiring glasses. That's a trifocal lens. But the downside is whenever you drive or sometimes in bright light, you can have those starbursts and glares and halos, but it is not necessarily that you'll have maybe 1 in 100 patients who doesn't have good neuroadaptation, or there is some phenomena, you might have that. So patients who are active drivers or type A personalities are excluded. The second range would be EDOF lenses. And these EDOF lenses, where we say that once you have a bilateral implantation, you will have mobiles and your routine screens you'll be able to see without glasses. But whenever it comes to fine print, you might need an add of 1.5. But that's good in driving. And the third would be the advanced monofocal. So we nowadays in our practice do not talk of monofocal IOLs, but we have stepped up. So at least stepped up by 20% of the revenue or the pricing of a monofocal IOL. So we step up by 20% of in this segment of advanced monofocal IOLs. Whenever we are talking of the insurance here, we would always bill or take the permission in terms of the advanced monofocal IOL, and where the billing would be at least 20% beyond the normal monofocal pricing. So that helps in 2 ways. It gives you that extra revenue generation. It gets you off the routine package system which the insurance has given you for a monofocal IOL, and you can charge over an extra to the patient under an undertaking that they have got a procedure which is giving you a good distance and a good intermediate. And the patients are also happy. Recently, I saw a patient coming up, operated at some other place, had a cystoid macular edema, was cribbing, but then he showed, look, the doctor gave me a very good lens, and this, they say, is an advanced form of a lens which is called advanced monofocal. So that patient was in fact teaching me, and that was what was very enlightening, that the patient also understands that this is different from a routine lens which is being implanted everywhere, and the lens I've got is a little advanced form of a lens. So I think all in all, it can be a game changer in our practice. You can push up your revenue with this lens. So actually over a 3-year period in my practice, now monofocals have almost died out, and we have converted the entire gamut into the advanced monofocal IOLs. And the patients are also happy. Once they have a bilateral implant, most of their need for the glasses withers off. So I think a good communication and education with the patient, simplifying the cost-benefit explanation, usually visual aids to demonstrate the differences, and offering the finance and payment plans to these patients actually in the initial days converts. But once you have a certain population who has then that itself becomes a self-driver for most of these patients. There is a lot of market demand for premium lenses and the patient expectations. So, but with this segment, since the patient has not paid a huge premium, but this lens still stands as a premium lens, so the expectations are not that high because they have not given you a lakh and above, which usually happens whenever you are doing a trifocal or you are doing a femtocataract with those trifocals read-offs where the billing would shoot up to 1.5 and the patient expectation would be like they have a magical vision. So the expectation vis-a-vis cost, vis-a-vis payment is all taken care with these kind of, this kind of segment. So I think balancing the affordability and the profitability and a high patient satisfaction with these lenses is what stands in my practice. A lot of studies which actually talk about this. So how to implement this? You train yourself, you be convinced, train your staff on the new offerings. You should have visual displays, update your marketing materials and the websites, talk about advanced. So patients are more thrilled to listen words like advanced, pro, plus. These are those catchy words which go with the phones and the market, providing patient brochures and natural online resources. So I think that's the way to go, and that's the way to push up our practice. Thank you, Sheetal.
Thank you, sir. Thank you for those excellent tips about how to place the lenses, and these were very practical tips, right? About the insurance aspects and how to counsel the patient and explain them the cost benefit and the other aspects. So Dr. Anurag, so what are your views about how you counsel the patient and also how you place it as a premium lens in your premium practice compared to a trifocal, let's say?
Yeah, so as Sonu sir has very rightly pointed out, this is one of his earliest sentences when he walked up to the rostrum. He said, you have to be convinced yourself. So for you to be convinced yourself, you need to choose, of course, we all are reasonably good cataract surgeons, so we do a good job with the surgery, but you need to choose products that are stable and consistent with their performance. Once you do that, and once you achieve that 95 to 99% achievement rate, this is what the IOL achieves in 95 to 99% of the time, you get convinced. Once you get convinced, you can pass it on to the counseling team, because it always reflects on their faces. Whenever they talk to the patients, the confidence with which they are putting forward or pitching the particular product, it always reflects on their faces. And once that is done, I believe, that's what I've seen in my practice, insurance is actually a big issue. Now, there are two things to be considered here. One is this undertaking that Sonu sir was talking about. Even if you get an undertaking signed from the patient, if you have a delta, this is what the insurance approves and this is what you've charged the patient, the differential amount you've collected and the patient gives an undertaking that I will not reimburse this, I will not submit this amount for a reimbursement later on. Even if the undertaking has been signed, it does not, according to IRDA rules, it does not stop the patient from actually doing it, going ahead and doing it. If the patient submits that bill for a reimbursement, what the insurance company will do is it will adjust that amount during the final settlement. So they'll cut your share by that much and then give the patient the 5,000 rupees that if charged extra or 10,000, whatever. So in my practice, what we do is after the patient is convinced, we tell them that we can neither give you, I'm saying this off the record if nobody is recording with the phone, we cannot give you a receipt for this. It's very simple. And I think we are justified in doing that because we are giving you a product which is head and shoulders above the other product that you've been choosing for. It's up to you. You either settle down for the approved amount or you pay us the extra amount and for which we can not give you any official document that we have collected this from you. And believe me, the figurative expression is, again, 95 to 100% of the patients agree. Many of the insurance companies are not even reimbursing for torics now. They're not even giving approvals for torics. So they have a slab. This is what you are going to get. Beyond that, whatever you charge the patient is absolutely up to you to manage, how you manage it. So the confidence which starts from the consultant then goes to the counselor. At the end of the whole process, if the patient is convinced that, no, this is what I want to go in for, the extra amount actually does not. That's what I want to impress upon you. The extra amount actually doesn't bother them. They do pay and they do get the best. But it's up to us, how do we pitch it with that confidence?
So while submitting for the insurance, you mention it as advanced monofocal or enhanced or monofocal
don't
plus or
understand these
only
terms.
monofocal or EDOF? Definitely not EDOF.
Definitely not it off, but
Yes.
they don't understand these terms, and
Yeah.
they have a bunch of jokers sitting in their expert panel, so they don't understand these terms. So of course, the sticker is there. If they want to find out more info, then they can. The identification card is also there if they wish to find out more about the product. But we don't normally, enhanced monofocals is something we don't write as enhanced monofocals because they don't understand it. It's taken as a monofocal only
Monofocal
by
only.
them.
Okay.
I'd like to just add to a point as part of the insurance committee. So what we decided was now shortly, I mean, the entire members will have that. So the lenses are now being divided, lens for distance, intermediate and near. So in the bills, we can always put in distance, intermediate, vision, enhancing lenses. So what we in our practice, I think that's I would differ from you in not giving a receipt, because then the patient can complain to different departments. Ki this doctor took the money and though no receipt is being provided, because then that comes under the radar of income tax also. So in our practice, so as a PPN network in our city, so when the MOU was being signed, we took it as a blanket cover that this is what you're getting reimbursed, this is what you're giving an X amount for a monofocal IOL. Any patient desirous of any premium or any femto procedure would be taken that extra amount. So what we do, or what we advise to the entire society in Rajasthan was that you take the undertaking, and once you are giving that pre-authorization, let that undertaking also go with the pre-authorization. So that while giving that permission initial, they know that this patient is opting for a package of this amount, where this is being given by the insurance and the rest amount is being claimed. So if they have any problem, they can there and then. So the AIOS fixed the star people this year, and shortly we'll have the results for this also. Secondly, I was discussing with sir, I mean, one of the great points can be advisory to all the listeners here, that whenever you have the patient coming on day one, and whenever you are making the patient read distance, intermediate, near, I always ask my counselors to come along, be in my chamber and see the results. So I think what I watch is the glory on the face of the patient and glory on the face of my counselors. And that is what actually reinforces, and this has actually transformed my smile results. So once they see that the patient is 6'5" the next day, with the same enthusiasm and the same confidence, they can actually convince the patient the next day. So I think making the counselor stand and watching for that post-op results is, I think, what reinforces the entire team and, kind of gives them that positive boost up. So these are small tricks and tips that, actually we can transform the practice on a daily basis. Thanks.
Sure, sir.
So no, you spoke very well, and in our practice, we have a category that this is going to be given to you by insurance, and there, the second category is you get a reimbursed, we'll give you a bill. The patient always agrees to reimbursement.
That's happening more and more now, yeah.
In that, you can change your diagnosis. You put it as a presbyopic IOL, you put it as an advanced monofocal IOL. You add something to your diagnosis which is more acceptable to the patient and the insurance. And we tell categorically to the patient, headache is not mine, headache is to the person who insured you. He is the person who is cheating you, not me. So they fight, and 1 or 2 inquiries you receive, this is what. But we always change, not monofocal, not advanced, it's either monofocal, toric, or presbyopic, or multifocal. So it is presbyopic correcting lenses or advanced monofocal. Once you define a lens, they look up on the net what it is, and they come to you with few answers. To mention here, I received a well good made gentleman from a business community. He brought me, I don't know from where. So this is the price of this lens marketed in the market. You have to charge only 80,000. You can't charge more than this. I don't know where did that mention that the price of implanting advanced monofocal or anything more than that was mentioned on the net. But this is how the patient gain information. So we save asking to fight with the insurance agent, not you.
No, it's actually our standard practice that when we give the breakup of the total value, the total sum collected to the insurance companies or to the patient, we write the price of the IL as the exact price we procure it at. We do not even scale it up by 1 rupee, and there's no limit on the professional charges that you incur from the patient. You can charge 25,000 rupees too, because there's no guideline as to where it needs to stop. So why shouldn't we charge for the professional expertise that we have inculcated by 15 years of hard work and 15 years of bone-breaking hard labor that we've put into learning things? So that's what I do. And what Sonu sir is saying is absolutely right. If the AIOS will come up with, because I have been after Dr. Nirmal Frederick to actually bring these points to focus. If they want to give us a certain amount, let them give a certain amount. But what the patient ultimately opts for is up to the patient and the doctor. The insurance company does not have a bearing in that. I think all the other insurance sectors, like the car insurance, for example, we all know that when the car goes to the garage for repair, we know that it will cover 70% of labor cost, 25% of consumable cost. We are prepared to bear this rest 75% or the rest 30%. So why should it not happen in the health sector is beyond me, actually. So I think steps are being taken, as sir is saying, and we would see a better future to establishing premium practice in India. But having said that, this is not a situation which exists only in India. This is a global situation now, everywhere. In fact, the insurance companies are behaving worse in the Western world than in India. So we just expect better days to come.
I think also in terms of the terminology, it may be safe to call it as distance and intermediate correcting lens, like as Sonu sir said, like rather than putting it into a category of presbyopia correcting or
you can, but
something else.
Only when it comes into their scheme of things as well. If they don't understand what you're trying to write, what you're trying to offer to the patient, then there's no difference between what you write. I mean, you can write that, you can write this, they will hardly
The point
understand.
is that they should understand.
Yeah.
Great. So those were some really interesting discussions. Do we have any other questions from the audience or any comments? So yeah, I think we finished on time. So I would like to, sir? Photo, yeah, we will take care. So I would like to thank my co-speakers, Dr. Anurag Mishra, Dr. Sonu Goyal, for the excellent talks and insights that they have shared on this relatively new topic and a new class of lenses that has now emerged and has become a standard of care in our clinical practice now. So thank you so much, Dr. Anurag and Dr. Sonu, for joining us, and all the audience who came to join this course on a Sunday early morning, and I hope it was useful and you benefited from these discussions. Thank you so much.
Thank you so much.
So can we join?